Highland. Welcome back to the Big Ideas Theater here at AARC Congress. So much education being delivered here at the Congress. Dr. Neal Thomas is with us. You had a session that was based on Pediatric Acute Respiratory Distress Syndrome in 2018. Do we have a consensus? Maybe I should ask that first. We've got other questions, but do we have a consensus?
We're getting there.
We're getting there?
A lot of work to be done, but we at least have a start.
Well, let's jump into the different conferences, and I want to make sure I get the acronyms proper here. But what prompted the ideas around the Pediatric Acute Lung Injury Consensus Conference, the PALICC, and the definitions for Pediatric Acute Respiratory Distress Syndrome?
Right. So as pediatricians, we never had our own definitions for Pediatric Acute Respiratory Distress Syndrome, or Pediatric ARDS. We had used adult definitions. The adult definitions were developed in 1999, were updated in 2012. And we found that they still didn't fit our needs. We wanted to define the children that we took care of in pediatric ICUs, and we wanted something specific for those children. So myself and two of my colleagues got together and said, let's try to get a group together and come up with definitions. We really wanted to focus on things that were pediatric specific and that would encompass all of the children that we take care of, and that led to the consensus conference.
Well, what are some of the differences between the PARDS definition and I believe the Berlin definitions?
Right, so there are a few major differences. The first one is that we use oxygenation index instead of PaO2 to FiO2 ratio to define the degree of hypoxemia that the child has. We felt that was important because if you use the PDF ratio, you need the P part or you need the PaO2. And in pediatric ICUs, a lot of times we will not measure arterial blood gases in these children. And so you could have the same child, and if I come in and draw an arterial blood gas, that child has ARDS. If one of my partners decides they don't need that blood gas, then they don't. That's not very patient specific. And so what we wanted to use was either oxygenation index or another criteria which we developed about 8 years ago called the oxygen saturation index, which uses pulse oximetry as our measure of hypoxemia. The other advance to oxygenation index is that it takes into account the mean airway pressure of the ventilator. So what I do with the ventilator impacts how the child's oxygenation improves or does not improve. And we felt that those two things are very important. Probably the most controversial thing we did, and we still don't have the answer to it, is we did not require bilateral infiltrates on chest x-rays. We required just an infiltrate, and it could be unilateral. That wasn't because we didn't think bilateral infiltrates were important, but it was because if you have two clinicians in the room, or a radiologist and an intensivist, no one has agreement on what an x-ray looks like. And so it was really just the determination of what bilateral infiltrates were that led us to exclude that from the definition, and we're doing some follow-up studies on that now.
Was that the most controversial item, you think?
There was a lot of controversy, but that's the one that's received the most feedback from the public. We've received a lot of letters to the editor and editorials and things, which is great. That's exactly what we wanted. We wanted to start the conversation. We knew we weren't going to finish it.
Can you update us on what progress has been made since the PARDS definition?
Sure. So we've, from 2015 to actually right now, we are continuing to look at data sets that we have and collecting data on children with pediatric ARDS to determine, first of all, if our definitions are valid. Second of all, are there things that we missed? Are there things like alveolar dead space ventilation or driving pressure that we didn't include in our definitions that we need to, and this is done with broad data collection. And then we just finished our PARDI study, Pediatric Acute Respiratory Distress Incidence and Epidemiology. It was a study of about 200 centers across the world that collected definition on almost 800 children with pediatric ARDS to validate the definitions, to look at the timing, and also to collect chest x-rays. So we have chest x-rays, the actual chest x-rays on this large number of children over the first couple days that we're going to use both to try to validate the unilateral versus bilateral question and use some computer modeling to see if there are better ways to determine infiltrates based on the x-ray other than clinicians looking at it.
Do you have a time window, if you will, as to when you would like to actually have these differences resolved?
Well, it's going to take years. We asked more questions than we could answer, at least in my lifetime. The PARDI study is completed. The first publication is now in Lancet Respiratory, which is just an overall epidemiologic study, and we're really starting to dive into the granular data related to some of those questions. Hopefully over the next couple of years we'll be able to advance the field.
We'll look forward to that. Future AARC Congresses,
Absolutely.
perhaps. Dr. Neal Thomas, thank you so much for coming by and joining us.
All right, thank you.
This is the Big Ideas Theater. I'm Ed Highland. Thanks for joining us.